Okay, good morning. Great to be here with you all. Ask the Secretary to call roll of attendance.
Director Kim? Director Sorrell?
Present.
Director Staines? Here. Chair Bott?
Here. All right, the next regular meeting is Friday, May 15th at 9 a.m. I have a motion to allow Director Sorrell to participate in this meeting as voting.
So moved.
Is there a second? Motion made and seconded. Any discussion on the motion? Hearing none, all in favor say aye.
Aye.
All opposed say nay. All right. I have any speakers registered to provide virtual in-person testimony?
We didn't receive any registrations nor any written testimony.
Okay. We'll go to our action items, to division chair reports presented by Dr. Lawrence.
Good morning, Chair Bott and Directors.
Good morning.
This morning I have I'm here with a request for 2 reappointments today for division chairs. The first is reappointment of the division chair of ultrasound within the Department of Emergency Medicine for a 2-year term running from April 1st, 2026 through April 30th, 2028 for Dr. Christine Jung. Dr. Jung attended CMS Medical School, did her residency and fellowship in ultrasound at Boston Medical Center. She first joined CCH in August of 2018. And the next request is for division chair within of orthopedic surgery within the Department of Surgery for Dr. Paul Lamberti, who attended Washington University Medical School, did his medical training at Loyola University with a hand fellowship at Indiana Hand Center. He first joined CCH in 2011, initially appointed chair in 2015, and this is for reappointment from April 1st, 2026 through April 30th, 2028.
All right, thank you. Motion to approve item 3A and the two proposed Georgia Hospital Division Chair appointments.
So moved?
Motion been made and seconded. All in favor say aye.
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 All opposed? All right, thank you. Along with the executive medical staff of Stroger and the medical executive committee of Providence Hospital reports and action items, Dr. Petronikos and Dr. Allegretti. Taking, so.
I don't see Dr. Patrinakos, but I do see Dr. Allegretti.
So let's start there.
Dr. Allegretti, did you want to come up?
Good morning, everyone.
Good morning.
Everybody received a packet listing the appointments and reappointments for Providence Hospital medical staff. And this was approved by the centralized credentialing committee in March and then approved on April 14th by the medical exec committee at Providence. And I'm here to ask your approval, and I'm here for any questions or comments.
Thank you. Motion to approve item 3B, the proposed Georgia Hospital, Providence Hospital Medical, or the motion to approve item 3B, the Providence Hospital Medical Staff appointments, reappointments, changes.
Second.
Motion been made and seconded. Any discussion on the motion? Hearing none, all in favor say aye.
Aye. Aye.
All opposed? All right, the ayes have it. Will Secretary move the Stroger Hospital appointments, reappointments, changes to later, or do we need?
I don't believe, if he's not here now, I don't believe he's going to be coming,
Okay.
but they were sent to you in advance for your consideration.
Okay. Can we have additional motion to approve item 3B, the proposed Stroger Hospital appointments, reappointments, changes?
So moved.
Seconded. Motion's been made and seconded. All in favor, or any discussion on the motion? All in favor say aye.
Aye.
All opposed? Say nay. Ayes have it. Okay, thank you. We'll go to the minutes of March 20th, 2026 QPS Committee Meeting. These were approved by the board at the April 10th meeting. Any corrections needed or any questions? Hearing none, motion to accept item 3C, the Quality and Patient Safety Committee Meeting minutes of March 20, 2026.
Second.
Motion been made and seconded. All in favor, or any discussion on the motion? All in favor say aye.
Aye. Aye.
All opposed, nay. Ayes have it. It's in the record. Now we'll go to our quality, safety, and experience dashboards. So I'd ask Raji Thomas and team to share with us. Thank you.
Yes, hi, Dr. Bott. This is Dr. McCormick. Just a brief introduction. We'll have our teams go over the dashboards that we've been promising you. These are the site level dashboards that we'll be using to track our progress and process improvement. Moving forward, as we present to the board, they'll be presented with less noise, a little easier for us to focus on what's in the purple, which is the areas that we're focusing on to improve. And so each of the site representatives will be going over their dashboards briefly today. So I think first up is Donica. So thank you.
Thank you, Dr. McCormick.
Thank you, Dr. McCormick. Good morning, everyone.
Good morning.
Donica Austin Caffrey, Chief Hospital Executive for Stroger. So in front of you is our Stroger Quality, Safety, and Experience Scorecard. By way of a little background, we are leveraging the Busy and Quality and Accountability scorecard to help us predict the projected performance of our CMS star ratings and leapfrog safety grades. This tool has our overall performance currently for Stroger, at 41.77, moving to the Vizient target of 52.58. And our overarching objective is really to improve also from 2 stars to 3 stars, again, by increasing the overall quality and accountability scorecard performance, again, from 41.77 to 52.88. The scorecard also evaluates performance across 5 core domains, which we will be focused on: mortality, safety, patient experience, effectiveness, and efficiency. The priority improvement areas are in the light pink and purple, which will help to move Stroger to the 3-star performance level. We've analyzed our peer performance and identified key areas where our peer organizations are outperforming us. These areas will serve to be really our primary focus for improvement. Moving into so by way of a little background, so Stroger
Monica, before, just on the mortality domain, this is just, you have a strategy and improvement plan and process, and we're just building upon that in terms of the focus.
Absolutely. And really our focus is really to look at 2 areas: our observed mortality and our expected mortality. So there is a group that is working on that, and currently the focus is really on our CDI education. We've identified 9 Vizient high-risk variables that will make the highest impact on increasing our expected mortality, and they're providing education to not only our attendings, but the residents on the 5 high-volume services in that area. Also, under our new structure, Stroger had its first quality committee on March 10th, where we reviewed the scorecard in the 2026 areas, and we identified with the Department of Medicine Council the areas of focus. Again, mortality reduction, patient-centeredness, so that nurse, patient, as well as physician interaction, as well as the discharge communication. Also, the quality leaders will be standing up additional councils with ED and trauma, surgery, anesthesia, and there will be other service line councils focused on the things that we discussed in terms of the 5 domains and reporting into the Stroger Quality Committee. Let me pause there to see if there's questions.
Any questions?
I also just want to highlight the focus and also the work being done on the always behavior at Stroger. So the 3 focuses of always kind, always considerate, and always connected. We've also developed a smaller scorecard really focused on where the survey items tie back to those behaviors, so that our leaders can understand the where we are and what our trajectory needs to be. The physician communication domain remains the strongest and most stable performing area. There's certainly opportunity in our nurse communication, as well as our responsiveness, and our biggest area in terms of nurses' ability to explain in a way that patients can understand, and also nurses listening carefully to the patients. Our clinical care continues to, remain strong, but again, our focus has to be, and the team is of the mindset and understanding that the patient connectedness has to be there for patients to feel understood, for there to be active listening with patients, as well as communication from the providers. Also, and this ties back into the patient experience, the responsiveness, teamwork, and also, communication about the discharge communication. Any questions?
And just for the benefit of the committee, the dark pink and light pink, in terms of distinguishing, is it in terms of, where the numbers land in the effort or focus area, prioritization?
Yes, the dark pink, the overall performance is really kind of the guiding star. And then the smaller pink areas under each domain. So for example, under mortality, we have mortality of oncology, mortality and trauma. Each of those would tie back to that higher green area, which is the 5 focus domains.
So we will continue to work on this reporting dashboard moving forward. Instead of listing all the areas that are currently listed, we might be showing more streamlined version of this dashboard where we would have the priority areas highlighted at each of the domain. But as this is the first version of presenting this type of cascading dashboard, we wanted the board to see everything, all the metrics that roll up to the domains that are listed there. So, moving forward, the discussion would mainly focus on those light purple areas, which are our priority areas. We're trying to model this report after the VCN report that we use internally to identify the direction of the movement of the metrics. So there is consistency across the system. We are using the same language. But we'll continue to work on fine-tuning this dashboard to make it easy to have the conversation around. I want to call out Danica for her leadership. Danica was the first leader within the system to stand up for council, a department-level council, and Department of Medicine has even gone one step further. They have their unit level, committees being stood up too. So, Danica, thank you for your commitment to safety and quality.
Thank you.
Thank you. Any questions for Donica? Okay, thank you.
Thank you.
Go to Provident Hospital now. Dr. Turner and Michael. Is Michael with us?
Good morning. Dr. Arnold F. Turner, Chief Hospital Executive, Provident Hospital. Good morning, directors. I want to review the Provident dashboard as just give an overview. There you go. The dashboard is aligned with the CCH strategic plan, and the goal is to improve the overall performance at Provident. As you see in the purple there, from 53.77% to a Visian score of 67%. And if we attain that goal, if Provident becomes able to receive a leapfrog grade, that grade would be B, and that's our intent with this. In the restructuring of our quality, we have the Provident Quality Committee, which is basically an oversight committee, and we have 3 councils, which are the emergency department, inpatient, and surgery anesthesia. And under there are 6 domains, which you see are mortality, efficiency domain, safety domain, effectiveness domain, which I can't see, the patient-centeredness domain, and patient experience. What's highlighted in what's been called light pink are the 6 metrics that we're going to focus on to move that overall performance score to our goal of 67%. And they fall under the patient safety domain and the patient experience domain. The one metric That's in the safety domain is the hypoglycemia and insulin use domain metric. You can see on the in the dashboard that at present we at 4.37%. We want to bring that down to 1.03%, and that is looking at the number of hypoglycemic episodes, patients that have hypoglycemia less than 50 over the number of patient days of insulin therapy, excluding those who present with DKA and hyperkalemia. Looking down at the patient experience domain, one of the things that we're all going to have to address in each council is that we have had a continued challenge with the response rate. These are based on HCAP scores. And so we still are going to have to focus on increasing the response rate. One thing that has happened is that we now have a patient advocate at Providence. That position has been vacant for about a year, and she's doing a good job now. I'm sure we're going to see some improvement in the response rate. And that would also...
Is that why there's no data there for 2025, where there's just not enough responses?
For...
At least I don't see any, what the current results
In
are.
2025 under the composite,
And it is, yeah.
the NISN safety domain.
in the safety domain.
We will get
Yeah.
that data.
And
There
the
is a
SEC
delay,
domain.
some of these metrics do have a lag of 1 to 2 months. That's an oversight on us, and I take full responsibility for that. We will fill that out for 2025.
Yeah, and then the comparison to what should be in the impact. So I think we're looking at the Stroger chart and then looking at this one. I think that's what directors.
Yep.
Thank you for, that was an oversight on our end, and we will fix it moving forward.
Great, thank you.
Okay. And she should also help us, in addition to the response rate in the surveys, also help us with respect to moving our grade forward and recommend the hospital. One of the things that this individual does is make rounds on patients that are newly admitted, and gives them what we call a patient pack, and make sure that their things are going smoothly for them during their hospital stay. We're finally glad to have that position filled as part of our staff. Moving on, communication with nursing. Mike.
Thank you. I'm Mike Moonen, Chief Nurse at Providence. Some of the things we are doing, again, trying to increase that survey response rate, rounding on every new admission. The communication with nursing aspect, we're trying to bump that up. We do have our house administrators running on off shifts. We have e-rounding that has been implemented at Providence. And, you know, we're also working, we implemented new whiteboards on the 8 West unit that basically can tell the patient, you know, what their nurse's number is, who their doctor is, what their plan for the day is, et cetera. So high level, those are some of the strategies that we are doing within nursing to improve nurse communication.
The next measure is discharge information. We're working on that with our nursing staff and also our hospitalists at the time of discharge, make sure that they're addressing the questions that are asked on the survey with respect to information regarding symptoms and problems to look for after discharge. And the staff, both the nursing and physician staff and our social workers, talk to the patients about help after they leave the hospital. And the remaining two categories are also HCAPs, which are recommended facility as far as ambulatory surgery, and also the likelihood to recommend an emergency room. These these are being cascaded down to our councils, which again are the emergency department, the inpatient, and surgery anesthesia. They are having their meetings now, being organized, and so when we come back, we'll have more fresh data and information about how we're proceeding to address these metrics. Any questions or comments?
Questions, comments? We'll look forward to the updated information.
Thank you.
The information on the 2025 numbers for the roll-up of all these metrics that makes up the domain is available, but we'll make sure we fill out the rest of the dashboard. And at the top of each of these dashboards, you would see the strategies that are identified as part of our strategic pillars for each of the facilities, and all the goals that they would be reporting out on moving forward are driven off of those strategies from the strategic plan. Thank you.
All right, thank you. We'll have Dr. Sharon Irons and Elizabeth Klavik join us for ACH.
Good morning, directors. Good morning. I am Sharon Irons, the Medical Director of Ambulatory Services, and
I am Beth Vaslovich, the Associate Chief Nurse Executive for Ambulatory Services.
Wonderful. So we are going to present information around our ACHN Quality Safety Experience Scorecard. We'll start with that, and then we'll also give just a little bit of information about what we're doing this year and how we've restructured, which all of that obviously is going to help us to overall improve our metrics. We'll start with our HEDIS metrics, which obviously is a really big focus in the ambulatory setting, and also on our dashboard we have patient experience. So really the ones that are highlighted here in this pinkish color are metrics that have to do with very important chronic conditions as well as prevention. And these metrics also align very well with what we're doing with our value-based care work. Our value-based care work with Wellvana, because we're, for all practical purposes, an accountable care organization because we have partnered with Wellvana since January of this year. So we will start with the prevention.
So looking at the prevention, we're looking at our cancer screening. So we have breast cancer screening for women, 45 to 75. You can see that our target is for 63. And as of the last month, we were at 66.3. So we've been doing well with that. We continue those initiatives. Our colorectal cancer screening, which is the new one, I know we had spoken about previously. So as it's new, we don't have a lot of back data, but we do have our 2025 score was 44.7. Our goal is, our target for this year is the 46.9, and you can see we're currently at 44, so there are efforts underway with our team for that. And then the cervical cancer screening, which isn't one of the highlights, but we do have a goal of 55.3, and we're currently at 63.5. So that's for our cancer screening. Right, Dr.
Thank you. So our chronic conditions that we're really focusing on include hypertension and diabetes. I will start with hypertension, where our desire is to control blood pressure less than 140/90 in our patient population, age 18 to 85. And what we have here is our target for this year is a 61% control. And as of now, we are almost at 60%. So we're doing pretty good overall with this. And I would just like to remind the directors that when we first started this work, pretty intensely back in 2020 with the pandemic, our rate of control was about 32% across the system. So this is really great work, I think, from our group in ambulatory.
What do you attribute that to? I mean, what did you do?
Oh, we did a lot. We partnered with the American Medical Association, brought them in, and they actually assisted us with a QI effort where we kind of trained all of our MAs and nurses throughout the system to measure our blood pressures accurately, because if you're not measuring accurately, you'll get a lot of high readings unnecessarily. So that was number one. Number two was acting rapidly, which is really working with patients to intensify their treatment and not waiting until the next visit in 3 or 4 months, but really bringing them in, partnering with our nurses in the clinic to adjust their blood pressure medicines within 2 to 4 weeks. And the last, which is MAP, the P part, is partnering with the patients, making sure that they are actually checking their blood pressures at home. So that's one of the QI efforts we did, among others, but I think that one was the one that had the most impact.
Thank you.
You're welcome.
Thanks for the continued attention work on these measures and sustaining quality. And on colorectal cancer screening, are there other strategies that you're driving to impact that?
Yeah, so we have several strategies in place. We do have our fairs where we go into the lobbies and we educate our community as they're coming in on the need for colorectal cancer screening. We look at our methods for colorectal cancer screening and partnering with organizations to see how we can improve those patients' screening. Some of them is looking at our methods for screening. We currently do FIT testing. How could we leverage things like Cologuard with the county care and others to identify methods patients might feel more comfortable for that screening process, so we're looking at that. And then how do we continue that process with them post-screening to know what the next step is.
So if you do FIT, do you have to do annually?
So FIT testing is done annually.
You have another question?
I'm just curious, like, if you did sonography, that's good for like 10 years or something, right?
You sure? Okay. Yeah, so there's different methodologies that can be used, and what is most cost effective actually is the annual FIT testing here. And so the colonoscopy can be done every 10 years. So that is another modality that can be used for screening, which we do for a few patients. But we do find the annual FIT testing to be more practical, more cost effective, and many of our patients just prefer not to have scopes, at least initially. Now, obviously, if the annual FIT test is positive, then they move on to have the colonoscopy.
Thank you.
You're welcome. So I was also going to talk a bit about the diabetes was the other chronic condition that we follow. Diabetes A1C greater than 9. When we say greater than 9, if an A1C level is greater than 9, that really indicates poor control. So we want the number to be less than 9. So the fewer patients that are greater than 9, the better. So this is an inverse metric. So what we have here is a goal for 2026 to have 34% or fewer patients having A1Cs greater than 9. So currently we're over that mark. We're at about 38%, and so we have some work to do in that area. We're actually trying to push more doing point of care A1C testing in our clinics, which makes it much easier because it's a finger stick. You get the result, and then you can act right away as the provider in terms of treating your patient, adjusting medication or whatever you need to do. Any questions about that? Okay. So we will, we also have obviously patient experience on the dashboard here, and I'm not going to go in a lot of detail about that. but basically what's demonstrated here is the top box score. And we are close to where we want to be in terms of our targets, and we'll have a little bit more information about that at our next meeting. But we did want to kind of review what we're doing this year, really to structure ourselves in ambulatory so that our overall effort with the quality work that we can do, that we're doing, will continue to improve. So if you could talk maybe about the primary council.
Sure. So we've been looking at, when we talk about ambulatory services, we typically fall into two categories. Those primary care, our PCMH, where the patients are coming in seeing their providers, and then the specialty care clinics when they're coming in for a special focus. In primary care, we're creating a primary care council that's really a triad. We have an operational leader, a physician leader, and a nurse leader. And they're going to be looking at several different components as it relates to primary care and quality. We'll be looking at our trends for our performance with patient safety, as well as things like our PCMH standards and our HEDIS metrics, and those things that impact value-based care, whatever's going to be impacting the primary care. And this council is going to be meeting monthly to discuss those items, to help identify and prioritize the issues at hand, to come up with PDSAs and performance cycles of how do we improve that metric and improve the quality that we're giving our patients. And then the other one is a specialty care clinic.
Yes, and so we will also have that specialty council in addition to the primary care. And that one's going to be pretty diverse. And so, you know, we have multiple specialties across the system. So one of the things we want to do with this council is bring folks together from various different specialties to really key in on a couple of quality improvement efforts that are common across the board. For example, referral management. You know, how long does it take to refer a patient, for example, to a specialty? What is the wait time? How many patients are waiting in queue? How do we get the third next available down? And we really want to look at that globally across the board, and we feel like that's something that would be in common to all specialists. We also, in addition to that, want to have a few of our specialty areas where we are focusing on some key items that are important to us at Cook County Health. For example, and we are going to allow the council to decide this, and that first meeting is coming up next week. But really, for example, how long does it take from the point that a patient, it's decided that a patient should have a procedure to the time that it's actually completed? For example, we might look at that in gastroenterology or orthopedic surgery. So we are going to take some focused specialties in addition to sort of that global issue as well. In addition to that, we'll focus on some things like patient safety, looking at root cause analyses, the trends around that, any EMERs that are a common theme across ambulatory. We want to focus on that as well. And we really want to also look at whatever affects regulatory and joint commission as a part of this whole effort that we're doing. Any questions about the specialty council?
Yeah, do you have any projections in terms of when you'll see positive change, or are you just going to monitor it and let us know when?
We are going to set some goals, and so that'll be part of probably the first couple of meetings that we want the council to decide not only what are the 2, 3, or 4 very important efforts we want to work with, but we want them to set those measures up front so that we can really have something to kind of target.
Those targets would be important and helpful for us moving forward, knowing when.
Absolutely.
We expect to meet them.
Yes.
So here in the next month, we will focus on patient experience, so there will be, much detailed discussion around patient experience towards the across the system. The following month, we will highlight some of the PI work that's happening at the council level, which will include, some of the, strategies that, Dr. Ian.
Thank you.
Thank you. And another thing, just for future, we can talk about is, I think we can connect the age-friendly measures work and to to Medicare wellness visit and the opportunity there, based on the ACHN numbers. So, thank you for the report. That's Manny Estrada from CERMAC.
Thank you.
Thank you.
Good morning.
Good morning.
Mandy Estrada, Chief Operating Officer for CERMAC Health Services. Good morning, directors, and thank you for the pleasure of being able to present our CERMAC JTDC Quality and Safety Experience Scorecard. I'll give you a real quick update on our structure and our establishment of our quality program at CERMAC. We've been working really closely with our frontline folks and respective directors for the service lines. We've established and had in place already our Behavioral Health Council, Mental Health Council. We have established for our own safety subcommittee, and ultimately have the structure that all reports up to the Quality and Safety Committee. Our medical council has been formulated. We're in process of fine tuning, but ultimately looking to how best to cascade the information from those respective councils up to presentation here at the board meeting. Our patient care services is also embedded into our safety committee, but they're independently also working on formalizing more so their council. Speaking specifically to the scorecard that we have here today for quality, safety, and experience, we have about 30 key metrics. From these key metrics, we've selected 5 to present here at review for you. A word of explaining why we developed the key metrics and how we developed the key metrics. Much of the work that we have going on at CERMAC is driven primarily at this point through our accreditation efforts. I'll highlight that we are currently accredited for our opioid treatment program, which was accredited this year. It's a 3-year accreditation process. We're going up to our second reaccreditation for the jail standards, which is also a 3-year accreditation process. This is the second series, second iteration, and for the first time ever, we will be we have submitted and will be surveyed for our mental health accreditation for the for the NCCHC. That accreditation for mental health will be a dual accreditation survey. It will be us and the Juvenile Detention Center. Our hope is, and I believe that we'll be aligned to be able to receive all 3 accreditations. And again, the key performance or the key metrics that we have here are aligned primarily to the accreditation standards, but also based on some of the patient care activity that we have been going on in the jail. Much of the heavy lift that we have at the jail is driven through the clinical services that we provide to the mental health caseload that we have at the jail, just at a high level. Approximately half of the population that we have at Cook County Jail is on the mental health caseload. So 2 of the key metrics that we have here are driven by the fact that we're looking at population, and a lot of the data that we have is driven by history and our experiences with the mental health population at the jail. I'll bring here that there's been a fluctuation in the mental health population at the jail. Although there has been some ebbing and flowing on the census in its entirety across the jail, by percentage, the jail population remains relatively high, probably at that 50% approximately for the mental health caseload. But what we have noted is that the population is more severely acutely ill. Our P4 population, which is the acute level of our mental health population, has increased, whereas some of the less acute population has decreased, and or should remain stable for the acute population.
I have a question.
Yes, sir.
When you say mental health and behavioral health are different things. Are you saying exclusively mental health or using mental health as?
I'm interchangeably using them. I apologize. It's the same nomenclature for us. Any other clarification? Or you're good. Okay, thank you. The focus of our key metrics are in lavender here. The first is discharge from, the Cook County Department of Correction, out of the jail that are, discharged with a petition and certificate. That means these, patients are deemed, either a safety risk to themselves or others and are unable to be discharged safely into the community. So we petition for these folks to be, discharged into an appropriate inpatient facility outside the jail because they are no longer remanded to custody. Our threshold was set at 10 based on what we had previously had as the trending in the past. As you can note, we've hit that on average at 12.3, which again speaks to the acuity of the patients that we have. It's our obligation to ensure that our patients, when they are discharged from custody at the jail, that we do our due diligence, assisting with reentry, but for the P4 population, which is again the most acute, that we do our due diligence in ensuring that they're admitted into the appropriate setting. The second indicator that we have is for involuntary medication. With the therapy and the individual counseling comes the need for providing appropriate pharmacological treatment based on our medical and mental health clinicians. Adherence to medication is important because ultimately at the end of the day, we want to make sure that our patients are receiving appropriate clinically. If there's an issue with med compliance, we will track the patient, do our due diligence, ensure that we are doing everything possible to provide the medication, offer the medication, the education, the counseling. Ultimately, we find ourselves in a place where some patients ultimately refuse. We have to petition the courts to be able to allow for the medication of these patients via court order. In the past, we had a limited number of psychiatrists available to do that work. We found ourselves at this particular point up to 100% with our psychiatrists being employed at the jail. We are running a zero vacancy rate with psychiatrists, so we've set a threshold of court-ordered medication at 10 per month. Again, that is driven by what we were able to accommodate. This process does include petitioning the court, so it's some of the process is beyond our control. It is a rather cumbersome process, and it's a difficult process, which it should be, because you're absolutely aligning it to forcing the patient to take medication for their own good, and it requires for us to do the work. We found ourselves at 6 for the quarter, which is a little bit under what we projected. Again, we'll be doing our due diligence to improve the process, provide the resources necessary via our psychiatrists to be able to do the work that needs to be done there. The other key indicator that I have is related to the medication compliance. We have a heavy lift when it comes to the activity we have in the jail related to access to care, which is some of the other key performance or key indicators that we have, but medication is a large percentage of the activity that we have at the jail. That means when we prescribe a medication, we want to make sure that the patients are able to take the medications necessary, either for their diagnosis or chronic disease, for whatever is ordered by our providers. We originally set a threshold, I believe it was at 90%. Prior to this, given some of the results we had in the past, we set our threshold at 96%. We've had some changes in the method that we deliver and document medication adherence at the jail to provide for a more safe environment. We've introduced technology. We've introduced barcode scanning. We've introduced mobile units to be able to document real time when medication is administered. That speaks to some of the fluctuation. We're getting the kinks out when it comes to our processes on documenting medication adherence. But nonetheless, at this particular point, we're running at approximately a 93%, where our goal is to be at 96%. We will continue to do the work to roll out the technology available to make sure that we do our work when it comes to medication administration. The other aspect that we have at the jail that is a little bit unique to us is that our patients do not have the ability to pick up a phone and ask to see a doctor. By standards, by policy, and by requirement, our patients need to submit what's called in a health service request form in order to access health care. 7 days a week, 365 days a year, we have folks picking up these forms that are exclusively and independently maintained by our medical services to allow our patients to request health services. Our requirements by standard and by policy is to respond to those health service requests within a 24-hour period. I'll just remind you directors that our census runs at approximately 5,800 at the jail at any given point in time. Any of those patients can submit a health service request to have access to healthcare services. And again, our obligation is to respond to and do a face-to-face intervention with that patient as clinically appropriate. Our threshold has been set at a 96% respectively for CERMAC Health Services and juvenile detention, because both of us have the same standard. At this particular point, it appears that we're meeting both standards. There's a lot of effort and energy. One of the questions related to this activity in itself, because access to care is the first step in the provision of health services to our patients at the jail. One of the higher driving work that we do is related to our patient care services and or nursing department, which is why we have probably the largest complement of our staff are nurses. That activity drives the access to care, the medication administration, and frankly, creating the hub of the work that we do in corrections. We will be preparing for the accreditation that will be coming up for the jail standards the latter part of June, and we are expecting our mental health, again, dual survey in the fourth quarter of this year. I'm expecting fully that we'll be in compliance with all three accreditation opportunities that we have with NCCHC, which will, knock on wood, position us to be recognized by our accrediting body as one of the few in the country that have all three, and thereby being able to be considered for what's called the Pinnacle Award for the organization. I'll open up to any questions and or comments.
Manny, thank you. It's been a while since you have presented at this board, so there was a lot of explanation that needed to happen. It's really great to highlight the work that's happening at CERMAC here at this forum. So thank you.
Thank you.
And I just want to point out to the board that this month, since some of these dashboards are really new and some of the metrics are being presented here for the first time, there needed to be a lot of explanation, but moving forward, it would be much brief, and we will focus on the improvements on each of the metrics that, we will continue to tweak, but we wanted our leaders to present all the metrics that makes up their, the measure or the domain here, so you are aware of everything that's being tracked, even though we will focus only on the priority areas. Thank you, Manny.
Thank you.
Just to refresh, while we line up the next presenter, I just want to refresh the board's memory. We presented to the board how the cascading of the councils happen. The board is holding us accountable to perform, deliver on our strategy for safety, quality, and experience. So we have an oversight committee at the system chaired by Dr. Mikhailis and Dr. McCormick. And then each site has their own oversight committee. So the CHEs and the COOs who are presenting here hold their departments accountable. So there is cascading there. And the departments are establishing work groups to make sure these metrics are moving along. And we will be here presenting on their performance. All right.
Thanks so much, Raji. Good morning, directors. So I want to start out by saying I frankly am a little bit envious of my colleagues, as clearly their performance management systems are far more advanced than what we have at CCDPH. We're much more early in our performance management journey, so I'm going to speak a little bit to the metrics and then really provide some context as to what we've accomplished to date in terms of developing our system and where we're headed. So I think a metric that's probably going to make the most sense to you all is the number of naloxone doses distributed. I think all of you are familiar with naloxone. It's a medication that's essentially it's over the counter. It's used to reverse opioid overdoses. And some of this work that we're doing is the work that I'm most proud of at CCPH because it's resulted in tangible saved lives. And so the work that we do there is essentially procuring naloxone at low or no cost, and then working and partnering with community partners to deliver that naloxone into various community settings, whether it's public transit, a library, a hospital, whatever the case may be. And just so you understand some of the work that goes behind this, it's very much in collaboration with partners. And so, for example, we worked very closely with the mayor of the city of Maywood to hold a community forum, invite partners in to identify where it may be most appropriate to have that naloxone stationed. And that really helped because then a lot of businesses came out of the woodwork because number one, they understood it was okay to do this, and number two, they very clearly understood the need. So some of the other metrics we have here, I would say just very frankly, sort of a little bit more challenging to interpret. Cost per inspection. I think what we're trying to get at here is essentially an efficiency measure. Definitely room for improvement, not so much with the measure itself, but like how we approach this. The same goes for the number of inspections processed per inspector. I suppose, again, this is sort of an efficiency measure, but I would argue, somewhat difficult to interpret and, subject to a lot of potential external forces. Similar case with the number of infectious diseases that are reported and that we investigated. I think the main message that we were trying to communicate here is that it's a big number. There's a lot of work that's happening in our communicable diseases unit. So that's the metrics, but I wanted to again speak to a little bit of context and then where we're going with our performance management system. So we're early. We previously reported data up to the Cook County Bureau of Finance as a part of the budget process. So for example, these are the metrics that go into the budget binder that's published to support the president's budget every year. We also report routinely on strategic plan goals for CCH and for the Office of the President. Those reports are essentially percent completion of various projects that we're engaged in. And I think that's important to highlight and sort of speaks to one of the challenge of doing performance management with public health, because our work is episodic. It's not repetitive over and over again. For example, with chronic disease prevention, a lot of the food work that we've done is, again, very project-based, working with internal Cook County agencies to purchase food that is healthier, locally produced, and so forth. So these are worthy endeavors. There are certainly opportunities for improvement that we could lift up and discuss, but I don't know that quantitative metrics are going to be the way that we capture that. So in terms of progress that we've made to date, we have worked towards developing work plans for each of our units. That is not something that we had before. But over the course of the last year and a half or so, we've iterated. We did one round that was so incredibly successful, and a more recent round where I and some staff were much more directly engaged with managers who had never, frankly, had to develop a work plan before. And I think this second round was much more successful. And as a next step, we'd like to have each of those tasks or goals or objectives that are in our unit work plans to be associated with performance measures. And again, some of those measures are going to be quantitative. Say, for example, you've got an environmental health manager who is wanting to improve the quality of inspections or improve, I'm going to use the word customer satisfaction, but it's really community satisfaction with the work that we're doing. There needs to be some background work that's done on our part to develop those systems both for measuring the community satisfaction and then managing that data. We don't have those systems set in place right now, and frankly, there also aren't necessarily national benchmarks or standardized metrics in the same way that there are for healthcare. I want to be clear here, those aren't excuses that I'm making, please don't hear that. It's just more the reality that we're trying to manage to. So we actually just met as an executive team yesterday to talk through like what the process would look like by which our managers would go about developing those metrics. Like what am I sort of communicating to them in terms of what we need for them. We intend to roll that out over the course of May, have finalized metrics available end of May that we review. And my hope is when I come back to you in June, we'll have like a nice dashboard that includes some quantitative metrics, some success stories, potentially some opportunities for improvement. Again, all to ensure that you all are able to do your job of providing adequate governance and supporting us in the work that we're doing. Again, looking forward to that discussion. Happy to answer any questions that you may have either about the metrics or sort of like where we're at in this journey. Thanks.
I have a question about the naloxone distribution.
Yep.
You know, we know this has been very successful.
Yep.
We do see all these stats, you know, decline significantly. So going forward, I'm just wondering if you know the locations of, you know, like where, you know, distributed.
Yep.
I'm assuming there are some locations may not be more, you know, effective or not well used.
Yes.
So are you like going forward planning to like evaluate where more effective locations and sort of move stuff around?
Yeah, so you're talking monitoring and evaluation, so you're talking my language, and absolutely. So, you know, zooming out from that specific tactical or programmatic question, one of the gaps that I've seen in our agency is that we don't necessarily have the appropriate monitoring and evaluation capacity that we need. And I say that because specifically the unit that oversees this work does. It has a monitoring and evaluation coordinator. And as I make asks for positions going forward, I'm likely going to be asking for those sorts of positions to inform some of the work that we're doing and ultimately feed into the dashboards that you're seeing. Honing in onto your specific question, yes, absolutely. We do look at where naloxone is being utilized and try to focus our efforts. I'd say, like, more specifically in terms of the areas that we put the most effort into doing outreach and engagement on this work, it's the areas where we're seeing the most overdoses or have seen the most overdoses. Yeah, thank you. Other questions?
Any other questions?
Thank you.
Wonderful. Thanks so much. Appreciate it.
It's a great example of how our commitment remains to continue to improve. This is the first iteration of the dashboard, but we'll continue to tweak to make sure, you know, the board is well informed of all the great work that's happening across the system. To that end,
good afternoon. My name is Emily Lupo. I'm the Director of Population Health and Performance Improvement at County Care. I oversee our quality program, and I'm going to speak to County Care specific, the quality dashboard for County Care. So I'm going to start with our overarching key objective, which is to obtain a 4.5-star NCQA health plan rating. We felt like this was a really good overarching objective, one, because it supports directional progress toward excellent member outcomes, but two, also supports us continuing to be competitive as a high-performing Medicaid plan in Illinois. As a reminder, County Care was the only Illinois Medicaid plan to earn a 4-star rating in 2025. And based on preliminary results, we'll sustain that for rating year 2026 as well. So we set some domain level goals and then individual metric goals to work toward that 4.5-star overall plan rating. What you're seeing for the domain level goals in green is that we are working to improve 80% of the priority metrics in 2 different categories by more than 5% as we're measuring data in the same month year over year. So I'll start with prevention and equity. We selected 6 HEDIS measures in that category that we're tracking very closely. Nothing is highlighted in that pink or purple color because everything on here is a priority for county care, and we have established performance improvement efforts for all of these items. So I'm going to start by highlighting some of the wins from February and March when we look across the dashboard. For February, for the prevention and equity measures, 3 of which are children and adolescent focused, and the other 3 are cancer screening focused, 100% of those measures improved by more than 5% year over year. The biggest improvement for both the months of February and March was for childhood immunization status, where we saw more than 100% improvement from February and March of 2025 to February and March of 2026. We attribute this to really 2 things. One, continued direct member outreach through county care and our providers and care management groups. And second, improvements in data collection, making sure that we're capturing everything that's happening within our broad network. I'll talk a little bit at the end about structure we have in place to work on all of these metrics, but I'll move next to the second domain level goal, which is the treatment category. For February and March, we saw 100% of the 5 priority measures in this domain improve year over year. The biggest improvements for the priority measures in this bucket were really related to hypertension control for members both with diagnosed hypertension and for patients with diabetes as well. The improvement in February for the top 2 measures in this domain was more than 250% from February 25 to February 26. We attribute that really to data capture. We're getting improved data from providers, and we're able to much more closely track where members are falling out of range. This is advantageous to us so we can intervene in a more timely manner and really more strategically direct member outreach. As far as structure, we will continue tracking year-over-year progress for all of the measures shown on our dashboard. Similar to other groups, we have established work groups. We call them quality work groups and not councils at County Care. We have organized them really by domain. So we have a maternal child health group, for example, a behavioral health group, a group really working on chronic condition interventions. And those groups do a few things. They continuously monitor the data, and they look at the data by segmented groups and populations, so we can really focus on specific subsets of our entire membership that need additional support. In addition to doing continuous data analysis, we also work on targeted interventions to address those identified either disparities or areas of opportunity. And so those work groups have been in place for many years. We'll continue to work on those areas of opportunity as identified. And then in addition to our work groups, we have a number of other sort of overarching strategies and supports for this priority measure list. Certainly member engagement opportunities, including outreach, member communications, member rewards and benefits is one of those overarching strategies impacting all 11 of the priority metrics on this list. Value-based care is another overarching strategy that we utilize, prioritizing and aligning provider incentives to ensure we're making progress with these measures. And then lastly, making sure that in our day-to-day work, we can also improve data capture. I'm happy to say a win from the past few months is we implemented 2 additional provider data feeds, extracting data from their EHR and using that to support improved month-to-month HEDIS reporting. So we look forward to reporting out on more detail on the performance improvement activities and continued trending on these priority metrics. do you include your health provider partners in your work groups, or it's just more complicated in a lot of ways just because you're not directly controlling it? You've got all the providers in your network. Some we do. So our maternal child health work group does include practitioners or FQHC staff from our network. Others don't necessarily, but we're always open to that. And I would point out that all of this gets discussed at our quarterly quality improvement committee, where we have a more robust provider representation as well.
And thank you for calling out our approach to improving systems and the processes here, that we don't just look at data. Our goal is to continuously improve. I really like how you pointed out that you're looking at year-over-year improvement. So great job. Thank you, sir.
Morning, Directors. Joseph Canis, Director of Accreditation and Regulatory. Provide you a regulatory update and some status updates. We had an unannounced IDPH visit, Stroger on a complaint visit last week for 4 days, April 7th through 10th. We are waiting on our official report. American College of Surgeons Trauma Center certification, Stroger. Have an update on this since our last visit. This was a visit that took place back on August 12th through 13th of 2025. We had one non-compliant finding. We were reaccredited as a level 1 through August 13th, 2028. We had an unannounced Joint Commission visit for a patient complaint back on February 17th. We were cited on a deficiency, and I have an update for the group since submitting these slides. We did submit our action plan. It was due at the end of this month yesterday, and we did hear back from the Joint Commission this morning, notifying that it was accepted and we are now compliant. So good news on that. Illinois Department of Public Health, outpatient dialysis, Stroger, this is the one we're still waiting on, expected at any time. We have the Cancer Center registry team, Stroger for American College of Surgeons. This is coming up in a little less than a week. This is a virtual site visit taking place next Tuesday, the 21st. Next slide, please. We have IDPH EMS Resource Hospital site visit at Stroger. We are scheduled for Thursday, October 22nd, so next fall. We have 2 for CIRMAC through the National Commission on Correctional Health Care. First one being mental health accreditation, which we touched base on earlier. We have a goal of a 2026 survey. We also have with CIRMAC through NCCHC jail accreditation. Update on that since our last meeting. We have a confirmed dates now of June 23rd through 26th. Also have IDPH perinatal redesignation Stroger, the date of November 19th, next fall. We have the Joint Commission Triennial Survey at Provident. It's an unannounced, and we're anticipating sometime likely between September and November. They came in 2023, the first week of December. And lastly, an update on the College of American Pathologists, or CAP for lab. They are doing a combined Provident and Stroger inspection, and the window they've given us is August 25th through November 22nd, 2026. So those are status of what's taking place and what's coming. Slide, please. This is just a snapshot of some of the triennial prep that's taking place as far as the preparedness rounds and multidisciplinary rounds that have taken place at Provident over the last number of months. And what I did here, just to make this a little simpler, is I put on the right-hand side, I've got top 6 findings. So what you're not seeing is data on this changes almost weekly, but these have pretty much stayed pretty consistent as far as our top 6. So we're finding expired products which we're able to take care of on the spot. Logs that are missing checks, which again we can educate staff with. Some of these are environmental, such as dusty sprinkler heads. We also have missing preventive maintenance stickers. We get in touch with clinical engineering to get those updated when we find things that fall through the cracks. Also dust and ceiling vents, and then lastly, expired hand gel. So that's the top 6 of things that we're finding during our rounds. Next slide, please. And this slide consists of what we're doing as far as regulatory preparedness at Providence with the triennial coming up and what's being done. So I'm just going to run through this. We're doing weekly multidisciplinary rounds, and that's some of the top 6 findings that you'll see listed in the previous slide. This takes place weekly, and it's a multidisciplinary team that rounds to the units. We have a calendar that we go from. I'm also running tracers where we're tracing patients through levels of care. We're looking at both chart review, any type of deficiencies, as well as staff practice. We're able to provide some coaching with staff as far as the information they provide so they can be prepared for the real deal. We are planning in May a mock survey for the triennial prep. We're working with an outside consulting group. We are also completing focused specific tracers. I list a couple examples here. Most recently, we're looking at sterile processing department and scope processing. We did launch a weekly quick tips alert. Basically what that is, it's a weekly focus point each week. It's a recurring thing that we'll do right up until the time the survey happens so that people can kind of think of certain areas, whether it's crash carts or egress, fire safety, things along those lines, just people to just be aware of and think about through the week. We also provided a survey prep tool that rolled out to all surveyable units. Go-to guide for when the surveyors walk through the door is that window between the surveyors present and they actually start doing rounds and running the tracers. They can do that, but then take and prep their units in advance of when the surveyors present. And lastly, this is coming up in the next few weeks. We're going to start weekly chart audits where we're going to review specific focal points on areas and look and see what we have for any trends or gaps in the chart so we can then close those gaps in advance of the triennial. And that's all I have. Happy to answer any questions.
Just a quick question about Joint Commission visit Georgia. Are these visits like you don't know like completely, or do you know like during this time there's gonna be visits?
So it's changed recently. So it used to be when they hit the 18-month mark, but with all the changes happened now it's the 6-month mark. So technically that 6 months is the first week of June. It'll go right through December. But we've heard from colleagues in the field that we can expect it, and hopefully, knock on wood, they come more towards the end of that. So we'll be prepared this summer, but we expect maybe they'll come through sometime after Labor Day weekend. We're here coming towards the tail end, but they are unannounced. And they used to give us a 30-minute notification on the Joint Commission site at about 7:30 in the morning, but they've since decided to eliminate that. So now it's just when they show up, they present the plan, goes into effect, so to speak. Any other questions?
No other questions? If there are no other questions, our agenda is exhausted. The meeting is adjourned.